Okay, hi everyone. So today we are having our second episode of the Referrology series on crystal arthropathy. We are very privileged to have Dr. Azizah, who is a rheumatology senior resident, to talk to us about this topic. So I think crystal arthropathy is one of those topics that most internists have quite a bit of exposure to. It's one of those things that we may be vaguely familiar with, but I think the purpose of today's session is really to delve into some of the practical challenges and day-to-day difficulties we may face with with this topic. So without further ado, maybe Dr. Azizah, you can just share with us about why crystal arthropathies, maybe in particular gout, are so significant and important.
Okay, thank you for the invitation for the discussion. There are a few types of crystal arthropathies, but I think for the purpose of today's discussion, our focus would be on gout. Gout is one of the most common causes of inflammatory arthritis, and it is important to recognize such patients and treat them early because it is often associated with a high degree of morbidity. Untreated disease advances the severity of gout and compounds the associated metabolic complications, potentially reducing long-term survival. So I think it's important to be able to recognize patients with crystal arthritis.
Okay, and just out of interest, not in the past, we always think that, like gout is one of those conditions affecting older patients and stuff. Do you tend to see like gout in like younger patients these days? And when is it that we need to start suspecting such, like the diagnosis of crystal arthropathy?
We actually do see a fair share of younger people these days, particularly young male patients who tend to be obese.
Okay.
Obesity is an independent risk factor for gout, so it's not uncommon that we see such patients. If we're talking about the diagnosis of gout, it is a clinical diagnosis, but oftentimes in younger patients, we'll need to entertain other causes of inflammatory arthritis as well. So it is not very easy, but with good clinical history and exam, oftentimes we're able to come to the diagnosis.
Okay, thank you. We'll move on to the next question. Okay, so Nick, do you want to ask the next question?
Okay, so maybe on a practical level, what's important to diagnose crystal arthropathy and particularly gout in the clinical settings when we see them on call or we're called to see patients with joint pain?
So I think that's a fair question. As mentioned earlier, gout is a clinical diagnosis, but there are a few clues which we can use to diagnose these patients. The first one would, of course, be the pattern of joint involvement. So typically, the first MTPJ, ankle and midfoot, are involved in gout. And particularly because gout tends to affect the peripheral joints, these joints are cooler and enable the precipitation of crystals. The second thing that will be important in delineating gout from other inflammatory arthritis would be the time course of the episode. So oftentimes these patients would describe an onset of flare which tends to be in the middle of the night or early morning when the joint is most cool. And it tends to result in maximal pain within the first 24 hours.
Okay.
Different compared to septic arthritis. In our patients with septic arthritis, they tend to report a more protracted course of the pain, so the peak is often 1 to 2 days later. Pertaining to the time course of episode, most patients with gout tend to have resolution of their symptoms in less than 2 weeks. Number 3 would be the fact that the key is actually the complete resolution between symptomatic episodes, which is peculiar to gout because the other inflammatory arthritis tend to demonstrate a more chronic course. Number 4 would of course be the presence of tophus, but again, this may not be evident in everyone, so we'll have to go by the clinical history. There are some other markers that we can use to diagnose gout. So laboratory markers that may aid in the diagnosis would of course be the presence of hyperuricemia, which is defined by the fact that the serum uric acid concentration tends to exceed the solubility threshold. That promotes the formation and deposition of the monosodium uric crystals. And at physiological pH, hyperuricemia equates to a value of about more than 360 micromole per liter. But having said that, the gold standard to diagnosis of gout will still be synovial fluid examination and demonstrating the presence of monosodium uric crystals. There are some pitfalls, unfortunately, in the diagnosis of gout. And that's number one, it can be polyarticular and chronic, which then makes it very difficult. But we do have diagnostic adjuncts that we can use in certain in those instances, such as joint radiographs, which particularly the hands and the feet, looking out for the classical erosions. Sometimes we also use the ultrasound to look for the double contour sign, which is essentially a hyperechoic band, which demonstrates the deposition of monosodium uric crystals on the surface of the cartilage. Dual energy CT scan is newer CTs that we tend to use more commonly these days. It is a non-contrasted scan, looking out predominantly for the presence of green pixelations, which signify the presence of the monosodium uric crystals. The second pitfall is that women also unfortunately tend to have gout, and the premenopausal women are actually protected because estrogen helps to reduce the increases the urinal clearance of urine. But we tend to keep a lookout in particularly postmenopausal women when they have lesser estrogen. And number three would be that there is sometimes in some patients, there may be atypical joint involvement, which then becomes very confusing because some patients with very advanced gout can present with symmetric polyarthritis, which may then resemble rheumatoid arthritis. But again, the adjuncts would be something that we fall back on to try and help us diagnose people with gout.
Okay, so you mentioned radiographs. When exactly will radiographs be useful? Do you tend to see changes only in patients who have had gout for a sustained period of time? In someone with a first flare, do you expect there to be any significant changes?
So sometimes we may not be able to see, so in patients who have, for example, first flare, we may not be able to see the erosions so evidently. Oftentimes it takes a couple of years, many frequent flares for them to demonstrate the erosions. But sometimes, having said that, some of our patients, if they tend to be on NSAIDs or prednisolone for some other reason other than gout, the presence of these anti-inflammatories would then suppress the gout flares, and they may not actually manifest a flare. But if they've got hyperuricemia in the background, they may well have erosions on the x-rays. And in such instances, then we may also discuss uric lowering therapy, but that will come to that a bit later.
Okay, sure. So you mentioned that the gold standard is that of a diagnostic arthrocentesis, but at the same time also gout is often a clinical diagnosis. So I guess the question would be, who should get a arthrocentesis? Yeah.
So to answer that question, I think we'll need to look to seeing why we're doing the joint aspiration. So the first thing would be for diagnostic purposes. So number one, to confirm the presence of gout. And number two, most importantly, in patients who present with monoarticular involvement, it will be important to exclude septic arthritis, which can occur concurrently. Number two would be therapeutic, to relieve the joint distension. So sometimes we in such patients presenting with gout flare, we also administer intra-articular steroids at the same setting, especially when septic arthritis is not a major concern, only after having had a look at the nature of the fluid that has been aspirated. If the fluid aspirated is very cloudy, we do not inject steroids, and we prefer to wait for the fluid analysis. So I think number one would be diagnosis to confirm gout. Number two, exclude septic arthritis. And number three, for therapeutic purposes. These would be the main reasons why I would offer a joint aspiration.
Okay, sure. Maybe moving on to the next question that you've partially talked about, uric acid levels. So uric acid levels in a gout flare, especially let's say, first presentation, non-crystal proven gout, what's the utility, and should we be doing uric acid levels in this context?
So I think this is a very common question that I've encountered during referrals. The thing is that although uric levels are elevated in almost all of the gout patients, they can be normal in about 1/3 of them who present with acute flare. And this could be due to various reasons. So number one, the acute inflammatory process itself drives the uric acid into the joints, reducing the serum urate levels. And number two, the interleukin 6 generation tends to exert a uricose-urate effect, reducing the urate levels as well. But having said that, it would not be wrong to send off a uric acid during an acute flare if there's no, especially if there's no recent value, because it may be high in those with very high uric acid burden, and it actually adds to the diagnostic value of the monoarthritis, for example, if that's what the patient presents with. But I think on the contrary, it is equally important to recognize that many individuals may have hyperuricemia in the absence of gout. And in the absence of symptomatic joint flares, tophi, there are actually currently no accepted indications for the treatment of asymptomatic hyperuricemia. But there may be an exception in some patients, especially those who have at a high risk of developing tumor lysis syndrome, those who are starting chemotherapy for leukemia, for example.
Okay. And you mentioned earlier that, gout and septic arthritis is a common thing that we need to rule out, but it can also happen concurrently. Is there any role for before going to the joint tap inflammatory markers, for example, CRP and ProCal?
So there are actually conflicting studies on the utility of procalcitonin and its role in differentiating septic versus non-septic arthritis. And I think the overall consensus is that it is not a very sensitive tool. So it may very well be just a suitable tool as an aid for rule-in diagnosis rather than exclusion of septic arthritis. So unfortunately, the gold standard to differentiating crystal arthritis from septic arthritis, especially in someone who has monoarthritis, as discussed earlier, would be a diagnostic tap. And the septic synovial fluid may contain monosodium urate crystals, and it is therefore important to send off Gram-stain smear and cultures, especially in the setting of high temperatures, leukocytosis, and marked elevation of ESR or CRP in a septic-looking patient. So it's a very clinical thing. It's difficult to say who may have a concomitant septic arthritis. So I would still recommend doing a diagnostic aspiration, particularly in someone who's just got one joint flare. Trying to differentiate between the two, especially on call, would be quite difficult. So if you have any clinical suspicion, it would be important to do a tap within the same night. And anything more than 50,000 leukocytes in ill-looking patients would be concerning for septic arthritis, and there needs to be a consideration for prompt orthopedic consult overnight.
Okay. So trying to just delve a bit into the clinical features, does the peaks of the temperatures, does the extent of the pain give you a good clue, or you do see patients with gout who have fairly high temperatures, you see people with gout who have quite significant pain also, and that's not so useful. What's your experience on that?
I think it's not very useful. We've seen patients with very high temperatures. I've seen patients with 38.8 with gout as well, and marked elevation in the ESR and CRP. So I think it's unfortunately not a very useful tool. But again, if the CRP and the temperatures are not very high, then I suppose that it may well just be gout. But if it's very, very high, then it becomes very hard to tell them apart, I think.
Okay, sure. So the next question is that about uric acid stones and urate nephropathy. I guess the significance is this is one of the criteria for consideration of uric acid lowering therapy. So how actively should we be hunting for these complications? And let's say in a patient who doesn't have active symptoms, yeah.
We don't actually routinely screen unless so it depends on we routinely screen patients who may be started on a uricose-urate lowering therapy, particularly probenecid, because it has a predisposition to the stone development. So we don't tend to actively screen in patients otherwise who have gout. But the typical screen that we use would be a urine dipstick to look at the urine pH. And sometimes if they've got previous abdominal imaging, for example, an ultrasound that demonstrates the presence of stones, then uric nephropathy is urolithiasis is one of the concerns. Then we would also offer uric lowering therapy in the setting of say frequent flares and hyperuricemia.
Okay, what are you expecting for the urine pH when you use it as a screening tool?
So we actually look at the evidence. We look at for the presence of a uric nephropathy. Sometimes we look for low pH in the urine, and if the pH is low, then we tend to suspect underlying uric nephropathy, and then we send them out for further workup to renal.
Okay, and for uric nephropathy versus just like let's say CKD due to something else, what would differentiate the two was like what you mentioned, is it based on the findings of urine dipstick. Are there any other features that would help you differentiate just concomitant CKD, let's say from due to hypertension versus it being a true uric nephropathy?
I think it's quite difficult. You would require a renal biopsy to tell the difference between hypertension-related, say, nephritis versus uric nephropathy. Oftentimes, you may develop stones, so you can see that. There is some people say that the stones that are evident in people with underlying gout, for example, are actually radiolucent. But you actually get calcium deposition within the stone, so you may be able to see stones as well in patients. You may be able to see the stones in patients with uric nephropathy sometimes. Okay. So the X-ray actually is pretty useful.
Okay, thank you.
Moving on to the next question. In the acute setting, I mean, how should we decide between colchicine, NSAIDs, or steroids? And then, like you mentioned earlier, who should be a candidate for intra-articular joint injections?
So the selection of appropriate therapy, I think, is influenced by quite a lot of factors. So number one, the patient's comorbidities, including renal, cardiac, hepatic, or gastrointestinal disease. Potential drug interactions, the duration of the attack that they have been experiencing, and the number and accessibility to the injection of the joints involved. So there are various therapies that are available for acute treatments, and these include number one, NSAIDs, number two, colchicine, number three, steroids. The common NSAIDs that we tend to use would be naproxen and acoxia. So naproxen is a non-selective NSAID, and acoxia is a COX-2 inhibitor. We tend to use COX-2 inhibitors in patients with underlying previous VJIT, for example, and it is and actually if you compare the NSAIDs, there's actually no difference between the different types. Colchicine is the other option that we have, and we tend to use it if the patients present within the first 24 to 36 hours, because it may not be very useful thereafter, given that it is a mitotic spindle inhibitor. Colchicine, special mention is that it needs those adjustments for those who have a creatinine clearance of less than 30. And in patients with hemodialysis or peritoneal dialysis, the current recommendation is a single dose of 500 micrograms and not to be repeated within a 2-week period. The next option that we have, so beyond the 36-hour mark, considerations should be made for the use of prednisolone. Usually about 20 to 30 milligrams daily for about 3 to 5 days, and 30 milligrams usually for large joints. If they present with monoarthritis, we tend to use intra-articular steroids to minimize the systemic steroid absorption. We tend to use intramuscular steroids sometimes for those with a very severe polyarticular gout flare. There is not much difference between the NSAIDs and steroids in terms of the time to resolution of symptoms, clinical joints status, or pain reduction, but certainly NSAIDs have been associated with more frequent GI or serious adverse events. Beyond these agents, then it becomes a little bit tricky. We have had patients who have got very bad renal impairments and who've had GI intolerance, say in the form of peptic ulcer disease or VJIT. In such instances, we may consider using ACTH as a stopgap measure. There are some off-label drugs as well, such as IL-1 antagonists, anakinra, which can be used for over a 3-day period as a subcut injection. Yeah, so these are the main therapies that we have currently.
Can I ask about the dosing for colchicine, both in normal patients as well as in renal impairment? How do you dose the colchicine usually?
So usually it's 500 micrograms TDS for 3 to 5 days, and you don't need to adjust the dose for if the creatinine clearance is more equal to 30 mils per minute. But for those with who are ESRF, for example, I think you just need to discuss with renal to see if they're okay. And we tend to just give them a one-off dose, 500 micrograms. Oftentimes in ESR patients, we favor steroids over colchicine because of the potential accumulation of the cytotoxins from the use of colchicine in ESR patients.
What about the in-between patients, those that are not ESRF and those that are less than 30 in terms of their EGFR? How do you
So if they are less than 30, then we tend to do a BD dosing for them.
Okay, sure. For a similar duration, is that correct?
Usually for 3 to 5 days, yeah.
Okay, sure. And in terms of, sorry, go Nick.
And for patients who just say have already had a dose, assuming normal renal function of colchicine for a 3 to 5 day course, but just say symptoms are not better, would there be a role for switching over steroids for another 3 to 5 days after that?
We can do that because if colchicine doesn't work within the first 3 days, then you are probably, and if they're still symptomatic, you can certainly consider steroids. There's certainly some patients who would have protracted course of flare, so we tend to use steroids, and sometimes even for the steroids, we tend to use a longer course. So we may go up to say 2 weeks, slow taper, maybe 5 milligrams every week if they're better.
Okay. And when you discharge patients, let's say with standby medicines for flares, do you have a preference amongst the 3 agents?
So if they have got no renal impairment, I tend to give them both colchicine 500 micrograms TDS for 3 to 5 days as the first line. And second line then would be prednisolone 20 to 30 milligrams 3 to 5 days once a day with PPI cover. So I tend to give both, and I tend to tell them to use the colchicine first. If it doesn't work within the first 2 days, then to switch over to prednisolone. But for renal impaired patients, we tend to give them standby prednisolone instead.
Okay, thank you. That's very helpful. Okay, maybe next we can talk about low purine diet. So I mean, we know that this is a very important aspect of the management of gout, but I think it's one of the things that we may not be able to, we don't actually counsel very well. So what's your spiel to patients usually when you counsel them about low purine diets?
So actually, contrary to popular belief, gout is difficult to manage just by diet alone. Because the purine content of the diet, if you were to ask the dietitians, actually, it only typically contributes modestly to total serum uric concentration of about, say, 60 micromole per liter. And why is diet alone not useful? Because if you simplistically, when you look at gout is due to either under-secretion or overproduction of uric acid. And in 90% of our patients, it is actually due to under-secretion. So the diet itself doesn't play a very major role. But of course, we do advise our patients to take precautions to moderate their consumption of purine-rich foods. And some of the purine-rich foods that the dietitians would often recommend to avoid would be number 1, red meat. So internal organs. Number 2, seafood, such as sardine, anchovies, shellfish. Number 3, alcohol. Number 4, fructose, so which may then come in the form of, say, sodas, fruit juice, and energy drinks. Some of our patients have also reported and asked about vegetables, for example. Studies have actually shown that moderate intake of purine-rich vegetables such as asparagus, mushrooms, spinach, nuts, and beans, they're actually not associated with an increased risk of gout. But what we often recommend to our patients to take would be a couple of things. So number one, coffee. Number two, vitamin C, at least 500 milligrams per day. Number three, low-fat dairy products like low-fat milk, yogurt, and number four, cherries. And all of these have demonstrated modest reductions in the serum urate levels and gout risk.
Okay, why is that so? I mean, why these particular food items?
No, it's just the way they are.
Okay, sure. Cool.
Things like nuts, is that a myth, or is it linked with gout flares?
Yeah, actually nuts are considered to be moderate purine-rich food. So not really, not as much compared to the high purine foods such as meat and seafood.
Okay, thank you. Okay, so next, this slide's quite busy. I guess we could go question by question. There's quite a bit to discuss about uric acid lowering therapy. So maybe we can start with who should be initiated on such therapy.
So the indications for urate lowering therapy, I think we had alluded to this earlier. And number one, of course, would be frequent flares. So those who demonstrate flares more than 2 per year. Number two, those with underlying urolithiasis or urate nephropathy. Number three, those with evidence of erosions on radiographs or say ultrasound. And number four, those with tophi.
Okay.
And the next question, I think, in the setting of an acute flare, would you go ahead and initiate the uric lowering treatment in the same setting, or would you advise maybe an outpatient follow-up and to initiate it when the patient is out of the acute flare? Because it's also believed that sometimes these can precipitate flares itself.
So actually, traditionally, I think we were thought that the urate lowering agents should preferably not be initiated during an acute gout attack to avoid prolonging arthritis. But in recent years, this view has been challenged. In fact, there was a randomized clinical trial that showed that initiation of allopurinol at low doses did not prolong acute treated attack. It is, I think, now believed that patients who present with an acute flare, they provide us with an excellent window of opportunity for discussion and potentially initiation of treatment, because most of our gout patients, unfortunately, are not the most compliant, and they often do not turn up for subsequent clinic visits because they're well and flare-free, but may then be repeatedly admitted for acute flares, which then increases the morbidity risk. So in those patients, then we make special concessions and we consider starting low-dose urate lowering therapy in patients once their acute flare is more or less settled.
Okay.
Yeah, so I think moving on, so if we, practically speaking, when we initiate allopurinol, what's a common starting and safe dose to go at, and how would you counsel patients?
So allopurinol is the first line, and this is the first line mainly for practical reasons, because it increases compliance because of it's a once a day dosing. The usual starting dose would be in patients with, for example, stage 4 CKD or stage 5 would be 50 milligrams per day. But in most patients, we start at 100 milligrams per day, and we tend to increase it titrate it over every 4 to 6 weeks. About 50% of our patients need more than 300, and we can actually increase it up to 900 sequentially. With regards to counseling, on allopurinol, we tend to tell them that there is a risk of GI intolerance, so diarrhea, nausea. There may be a small increase in transaminases, so which is why we tend to monitor them frequently. The other thing, of course, would be that most of us are concerned about would be hypersensitivity syndrome. So this, we tend to tell them that this tends to occur early in the treatment within, say, the first 6 to 8 weeks. And usually presents with multi-system involvement, so fever, rash, liver injury, as well as leukocytosis and eosinophilia. So if they've got any fever, they've got any rashes, oral ulcers, nausea, vomiting, we tell them to stop the drug immediately and to seek immediate medical attention with a medical professional.
Okay, you mentioned about, just to backtrack a little bit about the allopurinol dosing. So you mentioned you start about 100 once a day, and then you mentioned that you up titrate every about 4 weeks or so. So then the question is, on what grounds do you titrate? How frequently do you check the uric acid levels? And as you get to higher doses, sorry, can you hear me? Sorry, yeah. So the question is, how do you decide to up titrate? When do you check the uric acid levels again? And then do you split the dosing as the doses get higher?
Okay, so we see them, so this is not just for allopurinol, but for the other agents that we have as well. Most of our patients are followed up every 4 to 6 weekly. And there are a couple of things that we look at when they come and see us for their clinic appointments. Number one, whether or not they have, they're firstly compliant. Number two, whether they've got any adverse reactions to the drug. And number three, we check bloods on arrival, and these bloods include full blood count to look for cytopenias, their creatinine, liver function to look for any evidence of elevated transaminases, and number four, the serum uric acid. So we titrate the uric lowering therapy to a target of less than 360 or less than 300. Less than 300 for those with chronic tophaceous gout or very frequent debilitating flares. And the titration has to be done not less than 4 weeks. So, which is why our clinic appointments are always 4 to 6 weekly.
Okay.
And we tend to increase it to about 50 to 100 milligrams every visit, depending on the renal function.
Okay. And it stays as a once a day dosing, or do you have to split it?
Allopurinol is a once a day dosing.
Okay. Sure. So the next question would be the role of HLA-B5801 testing. Do you ever do it for any patients?
So I think in recent times there's been a lot of talk about HLA testing, and actually if you were to look up the literature, allopurinol hypersensitivity syndrome tends to occur in about 2% of those who test positive for this HLA. And if you were to look up the recommendations in the most recent ACR guidelines, it does suggest screening in particularly high-risk patients. High-risk patients would include East Asians, so such as Han Chinese, Korean, and Thai, and as well as patients with stage 3 CKD. However, the studies in the Asia-Pacific region have demonstrated that it may not be that cost-effective to subject patients to testing, especially for those in Singapore and Malaysia, for a few reasons. Number one, given the very low incidence of severe cutaneous adverse reaction. And number two, the high cost of the test. I think it's about 100 over. And number three, there is limited availability of alternative agents for the treatment of gout.
Okay.
And number four, even in those people who are HLA B5801 negative, severe cutaneous adverse reaction can happen in about 10% of them. So in clinic, oftentimes it's discussion with the patient and shared decision making. If they opt to test for the HLA and they're found to be positive for it, then we will not start allopurinol, and we will then treat them with alternative agents. Yeah.
Okay, thank you.
Maybe just a little bit more about allopurinol's hypersensitivity. Is it more commonly seen with higher doses of allopurinol, or is it more dose independent and can occur with any dose?
So traditionally, it happens at the onset of initiation, so within the first 6 to 8 weeks, as we said earlier. But there have been some studies that have actually shown that sequential dose increments in those people with sequential dose increments, some of them have also developed reactions. So it's a bit hard to say, but usually at the onset of initiation, people will demonstrate. If they ever have any severe cutaneous reaction, it will be demonstrable within the first 6 to 8 weeks. Yeah, but we tend to keep a lookup whenever we are increasing the dose anyway for all of our patients.
Maybe the next question would be about dosing of prophylaxis against flares during acid lowering therapy. How do you dose, and the choice of agents that you use?
So in terms of prophylaxis, I think the role of prophylaxis cannot be emphasized. Most of our patients who come into our clinic are oftentimes referred from the polyclinic, and they come in because they may have been started on a uric lowering therapy, and having been started on it, they have increased risk, increased flare frequency of, and this is actually a known fact. Starting someone on a uric lowering therapy would increase your risk of flare, which is why we actually advocate for the use of prophylaxis. So the use of prophylaxis cannot be underscored further. And the prophylactic options that we have currently are colchicine, number 1, and number 2, NSAIDs, and number 3, steroids. But usually we tend to use either colchicine or prednisolone. With regards to the dosing, in patients with a normal eGFR of more than 60, we tend to give a daily dosing, 500 microgram. If the eGFR falls between 46 to 60, we tend to give it 3 times a week. If the eGFR is say between 30 to 45, we do it 2 times a week. And we tend to avoid colchicine altogether if the eGFR or creatinine clearance is less than 30. And in those patients, we then opt for low dose prednisolone 5 milligrams once a day.
Okay. And how long do you cover them for this for the initiation of ULT?
So usually for we keep the colchicine prophylaxis for those patients who are supposed to reach a target of say less than 360. We keep it up to about 3 months after they've attained the target. And for those who are supposed to achieve a target of less than 300, those who are particularly with very frequent flares or those who have chronic tophaceous gout, we tend to keep it at least up to about 6 months, or sometimes up to when their tophi have disappeared. But sometimes the tophi might just be there, so we'll just keep it for up to about 6 months in those patients, and then we'll stop it altogether.
Okay, thank you.
I think the next question we covered earlier, the interval of following up. So usually about every 4 to 6 weeks. And so moving on, what are some other uric agents, and when do we choose them instead of allopurinol, besides the, for example, the HLA testing?
So the alternative to allopurinol is actually febuxostat, which is not a uricose lowering agent. It is a xanthine oxidase inhibitor. And we tend to use this when if they have got the HLA B5801 genotype positivity, as well as in those people who may have had allopurinol hypersensitivity syndrome. Unfortunately, there's limited data on efficacy and safety in people with renal impairments, particularly those with stage 3 CKD and in those on renal replacement therapy. So we tend to limit the dose to 40 milligrams once a day if their creatinine clearance is less than 30. Most people will need up to about 80 milligrams. So febuxostat 40 is equivalent to allopurinol 300. If you were to look up a little bit further, then there's higher cardiovascular risk quoted for the use of with the use of febuxostat. But I think it is difficult to draw a conclusion from that CARES study that looked at both allopurinol and febuxostat, because we're not sure whether allopurinol lowered the risk of cardiovascular related death or if febuxostat increased the risk. So, but in any case, we do tell our patients that there is a slight increased chance of cardiovascular death. So we tend to be a bit careful with using febuxostat in patients with ischemic heart disease. And we prefer allopurinol over febuxostat in such cases. The other uricose, so the other agents that we have are the uricose-uric agents, which you have mentioned. And these agents may be combined with, say, allopurinol or febuxostat, especially if they haven't attained their target. And it's not uncommon to see patients being on both. So some of the agents that we have are probenecid. The other agents are benzbromarone, lesinurad. So probenecid is a commonly available agent in Singapore, and we tend not to use it in patients who are overproducers. They cannot have a history of renal stones, which we discussed earlier, and they cannot have renal impairment. Their creatinine clearance must be at least more than 50 mils per minute. We tend to start them on prophylactic, say about 500 micrograms a day, and then we slowly advance them up to about 1.5 grams 2 times a day. Yeah.
Okay. So I guess for febuxostat, what's the cost profile like? Is it something very expensive, and can it only be started by a rheumatologist, or can anyone start it?
So it is unfortunately only available in the tertiary hospital settings, and which is why most of our patients who've been initiated on febuxostat in the hospital may not be able to be discharged to the polyclinic setting. It is certainly more expensive than allopurinol. Allopurinol is just a few cents. Febuxostat is about $4 a tablet.
Oh.
So some of our patients, so it's a rather expensive agent, and some of our patients may require social support for the use of febuxostat. So we tend to refer them early to our social workers.
Okay. And do you ever give uricosuric agents upfront ahead of allopurinol or xanthine oxidase inhibitor?
Actually, if you were to look at the studies, probenecid is one of the oldest and pretty effective drugs that are available because it directly targets it targets those people who are under secretors. But because of the fact that most of our patients do not drink enough water, because you need to make sure that you need to clear because it's a uricosuric agent, so you're clearing your uric acid through the urine and your renal tubules. So you need to be able to drink at least about 2 to 3 liters of water per day. And because most of our patients are working, they're dehydrated, they're not able to do so, we tend not to use that as first line. And also partly because it is not a once a day dosing. Allopurinol is a once a day dosing. So convenience sake, we tend to prefer allopurinol over probenecid.
Okay, thanks. That's very helpful. Okay, so next question is that of an OA flare. So this is a term that's thrown around quite a bit. Is there such an entity of things? What are your thoughts on this?
I think if you want to be very pedantic, I suppose anyone could have worsening of from their baseline symptoms for someone who's got osteoarthritis. I think the more important question would be to if someone presents with, say, acutely warm knee on a background history of osteoarthritis, it would be important to make sure that they do not have an underlying, say, crystal arthritis, which is not uncommon because crystals have a predilection for damaged joints. So most of our osteoarthritis patients may have underlying gout or CPPD or, say, pseudo gout. So that may then manifest as a flare, if you were so to speak. So sometimes to differentiate, we tend to aspirate the knee joint and just to see if we can demonstrate any crystals, and if it's inflammatory. If it's an inflammatory yield, then we tend to give them the treatment as per either gout or pseudo gout with colchicine or sometimes even steroids.
Okay. And I guess we've spoken quite a bit about gout. We probably don't have that much time to talk about the CPPDs and pseudo gout, but maybe you could give us just a quick word on like when to suspect CPPD. And maybe just a brief overview on the acute and chronic management for such conditions.
So I think CPPD in short is a disease that is commonly associated with our elderly patients, particularly more than 50 years of age. And there are several factors that predispose people to developing this and that we need to keep a lookout for, including primary hyperparathyroidism, long-standing low magnesium levels, hypophosphatemia, as well as hemochromatosis. And these things we tend to look out for, particularly in the younger people who present with CPPD. And I think it's very difficult, may not be very easy to tell it apart from gout because both conditions can coexist. But it typically tends to affect the larger joints, such as the knee, the wrist, ankle, elbow, and it takes a much longer time to resolve, up to about 2 weeks compared to gout. Most of our gout patients say that the flare resolves within 3 to 5 days. But again, I think to differentiate between the two diagnostic aspects would be the gold standard. Sometimes we may use the x-rays of the knee or the wrist to look for any evidence of chondrocalcinosis. And going forth into the treatment very briefly, the treatment is the same as what you got, NSAIDs, colchicine, and steroids. And just have to treat for any underlying predisposing factors such as low magnesium or hyperparathyroidism. We don't usually give them chronic treatment though for our patients with CPPD. When we treat the underlying cause, if there's any.
Okay. Thank you. So I guess we've discussed a lot today. Maybe for the listeners, are there any key take-home points or things that you want to highlight, perhaps based on maybe things you've observed as a senior resident, as a registrar, in terms of what should be focused on for the more junior doctors?
So I think for anyone presenting with monoarthritis in the correct clinical setting where you're not able to tell them apart from, say, septic arthritis, the first step would be to offer a joint aspiration. Number two, most of our patients, I actually feel that most of our patients are undertreated. So most of these patients, when they come into the hospital, they need acute therapy instituted early in their course of presentation. So they need to have isoling of their joints, number one, because that's a very simple thing that we can offer. Number two, if you have difficulty telling, say, septic joints from gout, other than putting a needle into the joints, you can give a trial of colchicine if you're scared to give them pred outright. So colchicine, as I said, it acts within the first 24 and 30 hours. If you miss the boat, it doesn't really help. So you can give them a quick course of colchicine. You can also try NSAIDs if there are no contraindications. If you're worried about using prednisolone, sometimes prednisolone may worsen underlying sepsis. And I think having a discussion early with regards to starting uric lowering therapy in our patients with especially frequent flares would be key as in the inpatient setting. And perhaps we should be moving towards starting them inpatient even.
Okay, thanks a lot, Azizah. Nick, do you have any other questions that you'd like to ask?
I think maybe just one last question about between NSAIDs, colchicine as well as steroids. Can we give them all together, or must we give like maybe one at a time?
I think you can give them all together. There's no issue as long as they do not have any contraindications. Yeah, but I would prefer not to use NSAIDs and prednisolone together though, because of the GI complications. Yeah.
Okay, thanks a lot, Azizah. I think it's been very helpful. I think the very practical pointers that you've given us, hopefully it will help the residents and the junior doctors be able to better manage arthropathies and really give you better referrals in future as well. So thanks a lot for your time today. Okay, thank you.
Thank you.